Hello everyone, welcome to HIM 225. We are covering chapter 14 in your textbook, and I would like for you to look at item number 2 on page 312, and this is psychoactive substance use, abuse, and dependence. And basically this is guidance on the hierarchy of how to code use, abuse, and dependence when they are all documented by the provider. So the first thing I want to show you is that in the index, if you go to use, you'll see alcohol listed here, and that code is Z72.89, and that codes to other problems related to lifestyle. Now, just because there was documentation that a patient was a social drinker or liked to drink wine, that would not be a reason to assign this particular code. You would only be assigning this code if in fact the provider documented that the use of alcohol represented a problem to that patient's lifestyle. However, I want to point out to you that there is a code for other drugs. For instance, cannabis, F12.90. You can see that there is a code here, cannabis use unspecified, uncomplicated. So if the patient is using these types of drugs, there are in fact codes that reflect that the patient is using them and it's uncomplicated. So I guess occasional alcohol is not something that typically we would code, but other drugs are. So just keep that in mind. Usually, if someone is documented as using these types of drugs, you can code them. Now, I want to go back to what the guideline tells us. It tells us that if both use and abuse are documented, that you only assign a code for the abuse. And that's because obviously someone who's abusing alcohol or a drug, that is more of a potential health risk than just using the alcohol or a drug. If both abuse and dependence are documented, you only assign the code for dependence. If use, abuse, and dependence are all documented, you only code the dependence. The dependence is the worst of the three. If both use and dependence are documented, then you only assign the code for dependence. So whichever situation exists, the abuse is considered the worst, the use is the least, and you code those accordingly with just one code based on the documentation of the worst situation. Now I also want to mention withdrawal, because withdrawal means that the patient has been using a substance, typically alcohol, and for some reason the alcohol has been stopped. They're not drinking, they can't get it, and so they develop withdrawal. And so if we see that if we go to withdrawal in the index, it tells us to go to dependence, drug by type with withdrawal. Now, usually patients with withdrawal may be seen in an acute care facility to manage the withdrawal, and then they may be transferred to another facility to manage the rehab portion of it. Or they might be, for the withdrawal, the process is called detox. And there are facilities that do a combination of detox and rehab. Detox requires the skills of a physician to manage the medications associated with that withdrawal process. So it's very important to understand the differences there. Okay, so let's go to okay, so if we have dependence, alcohol with withdrawal, we can see that the code for that is F10.239. Now, I also want to point out that many times when patients are in withdrawal, they also have additional problems. They may have delirium tremens, they may have hallucinations. Those types of things have to be managed, and they are coded. If we look at this code F10.231, we can see that this is alcohol dependence with withdrawal delirium. There's also a code for withdrawal with perceptual disturbances and withdrawal unspecified. Typically, the documentation is very clear to support these codes, and you won't have any problem assigning them based on the documentation that you have. So in the example, the last example that's on page 312, this is a patient that's gone to the ER, and the ER physician documents that that patient has daily alcohol use. And so the attending physician documents alcohol abuse. Well, if they do it daily, they may actually be an alcoholic and they may be dependent, but the provider has documented abuse, and so that's what we'll code. And so we can see that the code for that, abuse, alcohol, which says non-dependent, F10.10, and that's the code that we would use. Now, number 3 on the bottom of the page is psychoactive substance abuse disorders. And these are codes that are only assigned based on provider documentation if they meet the definition of a reportable diagnosis. The codes are only used when the psychoactive substance use is associated with a mental or behavioral disorder, and a relationship is documented. So let's look at some of these specific codes. So if we look at F10.9, well, let's see, we look at F10.99, alcohol use unspecified with unspecified alcohol-induced disorder. So that's probably not a code that you would ever apply. But when we look at these particular codes, again, we have to have the provider documentation of this condition. I apologize for scrolling through here. I should have gotten, let me get to one spot and stay there. So, obviously, when we're assigning codes, we're using the physician documentation and basing our coding on that documentation. And so as you go through these 0.9 codes in each of these categories, they are pretty consistent from one category to another with the way that the description of the codes are. Now, I'm going to, I want to show you a document that that is a new coding guideline that's not included in your book. And if you go to the chapter-specific coding guidelines and you go to chapter 5, you'll see number C. And here is the psychoactive substance use unspecified guideline. Now, this is a factitious disorder guideline. And a factitious disorder can either be imposed on the patient, or it can be considered to be Munchausen syndrome by proxy. And this tells us that this is a syndrome when the person falsely reports or causes his own physical or psychological signs or symptoms. And it tells us that the code for that is F68.1, and we'll look at this just a minute. And this is a condition, obviously, where somebody says they're sick and they're not. And it's consistent over time, not typically a child who plays hooky from school, but an adult who consistently makes themselves sick or reports signs and symptoms they don't have. And you may be very familiar with Munchausen syndrome by proxy. And this is when a caregiver, and often a mother sometimes, reports or causes an illness in their child or somebody in their care. Maybe an elderly person or a person has a disability, and they typically will give them something to make them sick, and then they take them to the hospital and say, oh, my child is sick. An example of a factitious disorder in an adult may be some of these people that report that they have cancer and have battled cancer, and they really don't have it. But if you Google Munchausen's, you certainly can find many examples of when this has occurred. And so I want to go back to, if I go back to the index, and in the index, actually, if we put in factitious disorder, factitious by proxy, we see that the category is F68. Other disorders of adult personality and behavior, and we see the one that's on self, and then the other one that is by proxy. And when we look at this guideline, this Munchausen's syndrome code is assigned to the perpetrator and not to the victim. And that's actually in the guideline. If you go to course content, you'll find these guidelines are in your course content, course resources. The perpetrator, not the victim, receives the diagnosis. So you assign this code on the perpetrator's chart or account. The victim who is suffering from this condition is assigned an appropriate code from category T74 or T76, which are the adult and the child abuse codes. So again, this code from F68 for Munchausen's by proxy is assigned to the perpetrator and not to the victim. Now, for this lecture, I want you to complete question number 3, exercise 14.2, question number 3. And I'm going to go over the homework next. For your homework, you're answering the odd-numbered chapter review exercise questions 1 through 23. And I can tell you that question 1 has 1 answer. Question 3 has 3 answers. This patient has Fragile X syndrome. They have an IQ of 25 and a family history of an intellectual disability. 5 and 7 each have 1 code. 9 has 2 codes. This is a patient who is an alcoholic and who also has alcoholic cardiomyopathy. 11 has 1 code. 13 has 2 codes. This is a patient who has dementia, and they are also wandering. 15 has 1 code. 17 has 2 codes. This patient has psychogenic asthma, so you have a code for both of those components. 19 has 1 code. 21 has 1 code. And this code is a Z code. And then 23 has one code. For the workbook, you are going to be completing Case Study 14.1. And there is another lecture for that case study that you can listen to that goes over that in detail with you. And that will conclude this second lecture for Chapter 14.